we need to do a little bit of clarification with the pathophysiology and diuretics used to manage patients with certain conditions. So let's start with thiazides. I asked you to know the indications, and it said essential hypertension, which is just like pre-hypertension or mild hypertension. So the thiazides we know are more mild acting, right? Mild acting. So you might see somebody who has like renal issues and liver issues, but there's a lot of volume in the body, and so the role of the diuretic is to pull that extra volume off. But the volume isn't so bad that we're worried about making things happen now. It's something like we talk about homeostasis of the body. So somebody who's getting thiazide and thiazide-like diuretics, they're usually more mild. And so the patient who's walking around is able to manage their symptoms usually at home. Diuretics, though, the loop diuretic is used up higher in that system. So the higher we go up in that renal system, the more fluid is there. So the loop diuretics work further up in that system, pulling a lot more fluid off. It pulls, it's the powerhouse of diuretics. So I say acute congestive heart failure or acute pulmonary edema. I'm looking at somebody who comes in acute means the condition has worsened versus chronic. I'm walking around with chronic congestive heart failure. I have some edema on my legs, but I'm able to do my activities of daily living. When somebody is brought into the hospital with an acute condition, that means that things have exacerbated. We talked today about class about how things go labile and how the body is in this regulation mode, right? It has to regulate. But when the fluid overwhelms the system, the body system, then we present with symptoms of tachycardia, increased blood pressure because the fluid volume is not being used, a low oxygenation, because when congestive heart failure, that fluid isn't getting pumped out of the lungs, so at the alveoli, that exchange of that oxygen and carbon dioxide, it's not happening. It's just not happening to the degree we need it to happen. And then you would expect the respiratory rate to come up because you got this fluid. Now the hydrostatic pressure is controlled by the pump of the heart. And in congestive heart failure, we talked about the cardiac output, the pumping of the heart becomes stronger. So as it's stronger, it's pumping, and the force of the pump to the fluid, on the fluid, is pushing that fluid out into the third space. So we use loop diuretics to manage people who have acute symptoms because it'll pull the fluid off faster. Thiazide's too mild. Loop diuretics, powerful, potent diuretic. Powerful, potent diuretic. So we say acute, this person would need oxygen, they would have to get the diuretic, and we want to pull as much fluid off. When we talk about people who are having acute symptoms, they will say that I put on 3 to 5 pounds in a day. That becomes acute fluid overload, so you have to remember that. So then the difference between a thiazide and a loop diuretic, thiazide, more mild, more management, chronic versus acute or full exacerbation. Now that's not to say that people who have chronic congestive heart failure do not get put on loop diuretics. But I want you to understand that their body, that loop system is broke. And we keep talking about the broke. So need a more powerful diuretic to maintain the fluid status in their body to help with the congestive heart failure, the high blood pressure, or whatever is going on with their body, that the pathophys needs a more potent diuretic. Now potassium sparing. Potassium sparing works differently on that loop within the kidneys, right? And so it's working on the aldosterone. The pathophys behind potassium sparing is hyperaldosteronium because so the goal with that, it's like an aldosterone antagonist. So it blocks aldosterone. So if somebody's making too much, then it's becoming a fluid volume. It's just increasing the fluid volume for hyperaldosteroniums. And it's because of a tumor on the kidneys, more like toward the adrenal glands. But so it's making too much, and so we use a potassium-sparing diuretic. It's not as potent as a loop diuretic because it's not working higher up on that kidney where all that fluid is primarily going in. Remember, as it's going through the whole process, all the fluid's coming here, and it gets filtered out as it's going through that whole tubular system. So if the loop diuretic is working up here, the thiazide and the potassium sparing are working down here, so it doesn't have to pull as much fluid off. Now, we will use potassium sparing diuretics in combination with other diuretics because of the potassium sparing effect it has. So it might not be as potent, but if we can use a lesser potent drug, a big gun drug, a loop diuretic, with a potassium sparing, we may not be able to have to replace the potassium as much. So that's how that's used. So then now we got osmotic, or the mannitol. Mannitol is an osmotic diuretic. So its job, when we talk about hypertonicity of a fluid, if you remember hypotonic and hypertonic, hypotonic actually pulls the fluid into the cell and makes the cell bigger, which goes against hypo, right? But the hypo is happening outside the fluid, so it's pushing into the cell, makes the cell bigger. We give too much of a hypotonic solution, we push that fluid into the cell, and then the cell will explode. It can lyse, so we have to be careful with that. Mannitol is a hypertonic solution, so what we're hoping to do is pull the fluid from the brain cells, and we shrink them as we pull the fluid out into the space where it can be absorbed into the body and then peed out. We only use it, the pathophys for mannitol is for brain swelling. It's for trauma. And I told you there's only 3 things we can manipulate. We can't manipulate brain matter, but we'll try. We'll take out a cranial plate, we'll pull it out, and then the brain can swell, and then we hope that the swelling would go down, right? We can remove cerebral spinal fluid, or we can manipulate the blood volume. Those are the 3 things that we can do to manipulate the brain swelling that's occurring. If we can get people, remember I keep talking about, if we can get people over that hump, then we allow the body to do what it does best, which is heal itself. So mannitol is an actual hypertonic solution that pulls the fluid from the cells and then puts it into the space so it comes out to shrink the brain, kind of. It shrinks the brain. So it helps with swelling on that way. But it is a diuretic. It is still a diuretic. So all 4 work at different parts of the tube. And you know what you guys are saying, what I'm hearing you say is, it works at the loop of Henle, it works at you know, at other places, and you name it. And I don't think you guys getting what that means. I don't need you to know that it works at this specific place, but I do need you to recognize that if it's working higher up on the kidney, and that's where all the fluid's coming in, then that loop diuretic is going to be more powerful, because it's working right at the junction, right, when that fluid comes in. So there's the pathophys behind diuretics. Acute is not cute, it's bad. It means that their condition is worsening. When you get into Med-Surg 1, you're going to be talking, well, Med-Surg 1 and Med-Surg 2, that's how they broke that down. One's an acute situation and one's a chronic situation. So knowing that congestive heart failure affects 6 to 10 million people, not everybody's in an acute phase. We can keep them pretty balanced with the medications we can give them. So that's it. Thank you, Chuck.